and then we'll hopefully kind of finish with some take-home points. I have no conflicts and no disclosures to admit. My objectives are pretty straightforward. I, again, would like to talk about the AAP guidelines, which were initially published in 2011, reaffirmed in 2016. I'd like to talk about some novel approaches to non-invasive urine collections in infants and toddlers. And finally, I'd like to talk a little bit about risk factors for urinary tract infections in older children who are already learning to toilet train or are toilet trained. So there are many people in this audience. I hope that all of you have seen this before. This was published originally in 2011 and reaffirmed in 2016. This is the diagnostic criteria for urinary tract infections. I generally find this very useful to kind of go over one more time in these talks and just kind of highlight some of the important points. So I think all of us now who are in a position where we're making these diagnoses have to understand that one, a child needs to have symptoms to make the diagnosis of urinary tract infections. Asymptomatic children should generally not be tested, I think. What qualifies as a symptom is sometimes subjective. So I often have referrals which suggest that foul-smelling urine would be a symptom. But I will tell you, most of the publications that looked into urinary tract infections use fever as a symptom, and I think that's pretty reasonable. Beyond that, the child should have evidence of pyuria, so that's leukocytes on urinalysis. And the child should have a positive urine culture based on a clean specimen. So what they mean by that is the clean specimen is obtained either through a suprapubic aspiration or through a urine catheterization. And the culture has to be at least 50,000 coliform units per milliliter of a pathogenic organism. So it can't be something like lactobacillus. It should be something more serious like E. coli. So that's just a little review for everyone out there. This is also quite useful. This was published again in the American Family Physician in 2012. It's basically based on the 2011 guidelines, and it gives an algorithm for office-based clinicians, family physicians, pediatricians, and emergency doctors who see children with fevers of unknown origin and who wonder whether they should continue testing these children or not. And so I think this is a useful algorithm. So I think for everybody out there, I think it's clear if you see a child with a fever of unknown origin and you think they have a urinary tract infection and they look sick, that child needs to be investigated with a urine catheterization and started on treatment immediately. But if they don't look sick and you're wondering whether you should do a urine test, then these algorithms are useful, especially if you're in the office and you're wondering about this, or whether you should see them the next day and reevaluate them. So these algorithms are based initially on gender. So male is slightly different than females. Males are also categorized whether they're circumcised or not circumcised. Uncircumcised males are slightly higher risk, and so they should be investigated with a urine test. And then the other categories, like the girls or the circumcised males, it depends on the risk factors. And the risk factors are similar depending on your gender, but it's not exactly the same. So fever, the number of days you have fever, and whether they have another source of infection is a key one. So this slide kind of goes to the value of a urinalysis and somewhat alludes to the value of a urine bag sample. I think most of us recognize now that urine bag sample is only good for a urinalysis. It's not useful for culture. It's not recommended in the AAP guidelines. And if you find anything in the urinalysis, whether it's leukocytes, nitrites, erythrocytes, some microscopy, then that compels you to do a urine catheterization anyways. So the only value for a urine bag specimen to do a urinalysis is if the urinalysis is completely negative. If it's not completely negative, then you are compelled to do a urine catheterization anyways. And why is that? This slide is kind of interesting, actually. It kind of talks a little bit about the value of a urine culture obtained through a urine bag specimen. And the issue is that the underlying prevalence of urinary tract infections in children with FUOs between the ages of 2 and 24 months is not that high. It's only 5 to 7% at most. Most of those children are likely to have viral infections. And so if your underlying prevalence is low, then your false positive rates from those urine cultures from a bag specimen are excessively high. So almost 90% for the overall population. In subgroups, which have an even lower risk for urinary tract infections. So the best example I could use is circumcised males, where the prevalence of urinary tract infections is exceedingly low. It's something like 0.2%. Then the false positive rate becomes astronomical. It's almost 99%. So at that point, you're basically treating 99 children to actually treat one children correctly. And so this emphasizes the fact that urine bag specimens are really not that useful to make the diagnosis. And so many of you may ask me, well, does that mean that all these children require urine catheterizations? And I would generally say yes at this current moment. And if you have difficulty doing them in your office or office-based practice, then I recommend contacting us either at the General or Centenary Hospital, where we can arrange those tests relatively efficiently in our hospitals to be done with our nurses and stuff. But is there, for example, an alternative method of collecting urine in a child which is non-invasive? So this is where we get our audience participation in there. And so I want a raise of hands if anyone has heard of an alternative non-invasive method of collecting urine samples in children. Yes, no, yes, no. Yes, no, just a few hands, which is I find interesting, actually. So I'm going to talk about two different methods for collecting urine samples in a non-invasive method in infants and toddlers. So this is the first method. It has the catchy name, the quick wee method, which was investigated in Australia, and they've done a number of studies with it. And basically what they've done here is they've cleaned the genitalia, then with a cold, wet cotton swab, they've stimulated the suprapubic area until the child voids. The other method, this is kind of a cute little video. So the other method is a little bit more labor intensive, as you can tell. It requires more healthcare practitioners and maybe not as practical in an office, but it is poorly named the bladder tapping and paravertebral massage method. And so that's what they're doing here. They're kind of tapping the baby's little bladder, and then they're massaging the baby's back. They clean the genitalia. It's a very cute video, I must admit. Yeah. And they get a midstream sample of urine, right? So, so the answer to the earlier question is yes, they are investigating non-invasive methods of collecting urine samples in infants and toddlers.
But only in males, right? Only in males. Males, boys only.
No. Girls and boys, yeah. Girls and boys, yeah. Yeah. Okay, so then the next question becomes, well, is this a valuable alternative method to collecting urine samples in these children? Can we get away from catheterizing all of them? And so I think the answer is not yet fully settled. I'll tell you that when you kind of do head-to-head comparisons with basically just feeding the baby, waiting to see if they pee, the frequency of collecting urine samples is higher than that. But it's highly age-dependent. So as you can imagine, it works much better for younger infants, less than 3 months of age, and it works basically less well for a child which is older, closer to 12 months of age. And I haven't seen any studies over 12 months of age where this is done, and I think in general it's impractical if the child's going to start fighting you while you start tickling them and stuff. So it is highly age-dependent is the first issue. Then the next question often is, well, can we accept urine cultures from these two non-invasive methods? So they are investigating this with different studies around the world, even in Montreal, close to us. And so there are head-to-head comparisons with urine catheterizations, and it seems to show that there is good correlation with urine catheterization and the rate of contamination that you get either from catheterization or through one of these non-invasive methods. Again, I think you're going to run into some problems with the sample size and the population in these studies, because the reality is a lot of these head-to-head comparisons are studying very young infants, less than 3 months of age, where the success of getting a urine collection is actually higher, much higher. So to give you an example, this is figures from some of those studies, which basically looks at the age and weight correlation and the success of getting a urine sample in those children. You can clearly see that younger than 3 months of age, There's reasonable success rates like 80, 90%, but there's then a drop-off which tails down up to 1 year, and it gets close to 20, 30%. So I think at this point, I would not recommend this beyond using it as a method of getting a urine analysis to make your decision tree further along. I think looking forward in 2021, when we expect the next revised guidelines from the AAP, I would expect there to be a mention about a non-invasive urine testing in infants and toddlers, but I don't think we're there yet. It's just something that's coming on. So I'd like to move on a little bit further about risk factors for urinary tract infections in slightly older children, because I see a lot of these patients as well. And I think all of you as clinicians probably know many of these risk factors. They're pretty self-evident, and I think the issue is more just getting into the details. So for sure, constipation is a big one. Personal hygiene. I find it seems to be much more important in young little girls than young little boys. Issues about frequency of bladder emptying, making sure they're emptying all the time. There's some other issues as well. There is a slight possibility of urological abnormalities as a risk factor for urinary tract infections. But I will tell you that 80% of the urological abnormalities that we find are diagnosed before the age of 2. So if you're looking at a 3 or 4-year-old kid and you're wondering why they're getting lots of urinary tract infections, it is more likely, wait a second, one of the first 6 risk factors. Which gets me into the last bit of my talk, which is, this is another audience participation one. So this is a funny one a little bit, but I mean, this is something that comes up to my clinic quite a bit. So I often see a lot of these kids with urinary tract infections, and I have these long conversations with these families about the proper way of using a toilet, right? And then I get some funny conversations about that. But we'll get a raise of hands. How many people believe number 1 is the proper way of doing this? Number 1, no. There's a lot of reluctant people out there. Okay, how about number 2? Anybody for number 2? Anybody for number 2? Maybe. Number 3, that looks kind of funny, probably awkward. Number 4, anybody for 4? And number 5. Okay. Okay, so I find this kind of part of my talk kind of funny, but I actually have this conversation a lot in my clinic, and it's a very important point. And I must actually first explain that I'm a nephrologist. I only worry about the kids peeing. I don't tend to worry about how the kids poo so much, as long as they're doing it. So I think Latifa might have a different answer, but I will say that to my parents a lot that the toilet seat looks like a chair, but it's not a chair, which I think is kind of funny. And you're never meant to sit on a toilet seat as if it was a chair. And a lot of kids are doing this the wrong way. They're basically sitting on the toilet seat with their legs together and their backs up straight. And by doing this, especially little girls, they will pee into their vagina or on their vagina, on themselves. And so by doing this, they cause a lot of irritation, inflammation, and infections. And this is what results in vaginal voiding. So what is vaginal voiding is exactly like I explained. They're peeing into the vaginas. The vagina anatomically is like a pool where the urine stays. This results in complications. All these complications I do see in my clinic. So the girl, after she finishes voiding, or she thinks she finishes voiding, she'll pull up her undergarments, leave the toilet, and then often the mother will find urine, just a couple drops of urine in her undergarments, or some vaginal discharge, some whitish discharge. And this is occurring because of how she's actually sitting on the toilet. So I tend to recommend that little girls basically sit on the toilet with their legs apart, leaning forward. Or when you think back to the previous slide, I actually ask them to turn around and face the toilet bowl, because by turning around and facing the toilet bowl, it automatically puts them in a position which is anatomically correct to void into the toilet. So the correct answer was actually number 4, which I saw Dr. Kitai actually got. Good for him. So this is a fluoroscopy of vaginal voiding. This is a little girl who is peeing through her bladder, and you can see it. This doesn't come out quite so nicely, but it does come up into her vagina like that. And that's an example of vaginal voiding. This is a very common thing I see in my clinics. I'll talk to them. I'll talk to the families, explain to them what the problem is. The kids will be much better after this. I would still also talk about all the other risk factors related to urinary tract infections, but this is one I find that is overlooked quite a lot. So a couple take-home message. I didn't want it to be a very long talk because I knew I had 15 minutes. So I think I would recommend everybody who has the opportunity to find the 2016 guidelines for urinary tract infections, go over that diagnosis, and just go through that process of how that diagnosis is made. I think in this way we will identify and treat the right number of kids, and not overtreat any or underdiagnose any. I think all children with urinary tract infections, when they are first presenting, should get an abdominal ultrasound. That was one of the recommendations, and I do agree with this. The other recommendation is that they are doing less VCUGs, which I do support as well. I don't think we need to know all the mild or low-grade vesico-ureteric reflux. And the severe grade vesico-ureteric reflux, then we tend to think that we would find hydronephrosis or some dysplasia or so, although I must say the correlation with ultrasounds is not great. The patients I actually want to see are the patients who you worry about that child could actually have real kidney disease. And through what I mean by real kidney disease is, does that child have some scarring? Does that child have some associated renal dysplasia? And those are the patients I do like to see. So if you're worried about these things, do the ultrasounds, get their height, weight, blood pressure, do your analysis, and just consider, and I'd be happy to see those children in my clinics. Thank you very much.